So urinary blockages pose various risks, not only the fact that they're unable to urinate and their bladder is potentially enlarging and going to rupture, but the inability to urinate can cause them to develop hyperkalemia. They're not getting rid of potassium the way they should be, which sets them up for a high risk of cardiac arrest. This can also cause bradycardia, and again, you'll see their serum potassium levels greater than 6. Treatment, sodium bicarb, calcium gluconate, and dextrose. Try to bind it and get rid of it. Minimizing stress, because you have to be careful. That stress causes an epinephrine release, cardiac arrhythmias, and they're already having cardiac issues. Depressed blockheads may not need general anesthesia. You may be able to block them without putting them completely under. But inhalants and propofol are usually good choices. The propofol will sedate and then induce them, and then you'll have your inhalants, so you can avoid a lot of the complications, bradycardia, caused by a lot of the pre-meds that are used. So how are you supposed to respond to these problems? What's your role, the general approach to emergency, and emergency situations during anesthesia and recovery? So, in general, the veterinarian is in charge. However, they are most likely performing the surgery, which means you're the one who's actually realizing that there is a problem. So you need to be prepared to take an active role. First of all, communicate. Communication between the tech and vet is crucial. Make sure you let them know there's a problem, ask them what's going on. I was once monitoring anesthesia, and all of a sudden the blood pressure tanked, and the vet went, oops. Apparently had nicked something, fixed it, blood pressure came right back up, though in the meantime we had been scurrying and dropping down the ISO and bumping up the fluids, etc., etc. Be familiar with the crash cart and fluids that are present. You don't want to not know what's on hand or what you need or what you have available. So again, when you have downtime, check out the crash cart, make sure you know what fluids are there, what fluids you have hanging, and have procedures in place in case there is not a vet present. So if you're, maybe still getting the animal prepped, or you're in recovery and the veterinarian has walked out of the room, what can you do? Most states allow the technician to perform life-saving care in the absence of a vet if there's a protocol in place, and most likely they're somewhere in the building anyway. But make sure you know what the CPR protocol, life-saving protocols are, so you can just jump right in as you're shouting for help. So not every emergency may be the same. Make sure you know if this owner is going to elect to resuscitate or not. That's something usually you ask before surgery or even on an emergency, what their resuscitation stance is. If it's a severely ill animal, it may have a DNR. Also, cost considerations. How expensive are things going to be in the long run? People may not be able to afford a lot of life-saving, doing it over and over again. If you need to, take a quick second and gather your thoughts and contact the vet. Usually the vet or most senior person will take charge, at least initially, though that may someday be you. But in the meantime, obtain or delegate someone to bring in the cash cart. Use closed loop communication, so that way you're not just saying, somebody get the crash cart, and leave it wide open. Somebody needs to answer you and say, I'm getting the crash cart. That way you know your comment's been heard and that somebody is answering it and doing it. If you leave things hanging, all of a sudden, who's on first and no one has any idea. At the end of the day, do no harm. After the event, no matter how it's turned out, discuss why the emergency happened with your team and evaluate the team's performance. What could have been done differently? Did everything go well? What would be better to have on hand? Is there a way this could have been prevented or done better in the future? So these are some common events that happen during anesthesia for various reasons, which we will discuss. The patient will not stay anesthetized, becomes too deeply anesthetized, their mucous membranes become pale, prolonged CRT, cyanosis and dyspnea, tachypnea, heart rate and arrhythmia issues, respiratory arrest, and cardiac arrest. So your patient will not stay anesthetized. What to check? First of all, are they getting anesthetic gas? Is the setting changed? Is it too low? Is there actually anesthetic in the vaporizer? Second, ET tube placement. You can check this with rebreathing movement, though also want to palpate. You may even have to take a peek in there. Sometimes the ET tube, as many of you know, goes into the stomach, and there can be enough pressure from the lungs that it will look like very small breaths are being taken in the rebreathing bag. So when you intubate, make sure you get that really good fog. You can feel the breathing through the tube, not just a maybe, but a definite feel. And as I said, you may have to get down there with your laryngoscope and look to make sure the ET tube is actually going into the trachea. Is there air leaking around the tube? You can bag the patient and listen for air leaking at the patient's mouth. So maybe you don't have your cuff inflated or inflated properly, or there's a hole in the cuff. Apnea, character of respirations. So are they breathing shallow, or are they taking normal breaths? You want to make sure your machine is correctly assembled. Did you leak test it? Is everything together, or is there gas leaking? Oxygen flow rate. Don't forget, a minimum of 500 milliliters is required, or 0.5 liters. We usually use 1.5 or 1,500 milliliters. Very high flow rates or repeated use of CO2 flush will also dilute out your anesthetic gas. So if you have it up at 5 or at 4, or you're flushing a lot, they won't be getting as much anesthetic gas as they may need. The machine function. The vaporizer needs to be serviced if a 3 or to 4% setting is needed to keep the patient under, especially without any pain or anything like that. If the patient's just having, even during induction or, after it's been closed or whatever, and you're needing it to be that high, you need to potentially get your vaporizer fixed. Agonal breathing. So you don't want to see this, but if you do, that's really exaggerated respiratory movement. Pretty much comes when the patient is too deep and are about to die. It's like big gasping breaths. So, are they too deeply anesthetized? Signs like this, respiratory rate less than 6 breaths per minute. Now, that being said, some of us have seen the dogs try not to breathe for a while. It's not necessarily because they're too deep. Usually it could be an effect still of the propofol in their system, but ideally once things normalize, they should be at about 6 breaths per minute to ideally more like 10. Are they taking shallow breaths or are dyspneic, so they're barely breathing at all? And are they getting pale or blue mucous membranes? Is their CRT increasing, bradycardic? Is their systolic dropping? Also, you can also check their MAP. What do you want their MAP to be at, or if it's getting below, what should cause concern? Cardiac arrhythmias, cold extremities, hypothermia. Don't forget when the body starts to go in signs of shock and into failure, all the blood gets concentrated to the vital organs, so those extremities will get cold. Reflexes will disappear even more, especially corneal. This is a little bit more useful in large animals, but that does go away when they're too deeply anesthetized. Their muscle tone will become flaccid, not just movable, but limp noodle. And their pupils will dilate, an absent PLR. That's the whole, his pupils have blown type of thing that you hear on grays all the time. So, use care when interpreting signs. If you only see 1 or 2 things, don't suddenly jump up and say, the patient's too deep, and turn off the isoflurane. Make sure you think about everything else that's going on, their heart rate, how does everything feed together, the pre-meds and other anesthetics that are being used. Again, don't forget, propofol can cause them to be apneic at the beginning, but then once it's out of their system, they start breathing normally. So, and then why is the patient too deep? If you have established that they are indeed too deep. Is the vaporizer too high, too much injectable meds? Are they shock or anemic, which could make them more susceptible to a drug overdose? Or don't forget some of those conditions we talked about earlier with geriatric patients, pediatric patients, skinny patients like your sighthounds. So you've noticed that their mucous membranes are pale. Obviously, first cause could be anemia, which hopefully you know about before they go under anesthesia. This can happen in certain cases such as FELV, IMHA, bleeding disorders, neoplasia, renal failure, but also if there's blood loss during surgery. Drugs also can cause vasodilation. So if you imagine it, imagine the vasculature is a certain size and then it suddenly gets bigger. There's less resistance, so that will decrease the blood pressure, causing poor peripheral perfusion. And this is often a sequela to inhalants, ACE, bromazine, and propofol. Hypothermia can cause pale or mucous membranes, and pain. So you want to make sure they're not too deep and monitor their vital signs. Make sure they are actually breathing, getting enough breath, their heart is pumping, circulating, aren't any arrhythmias, things like that. You want to make sure you rule out hypothermia, hypotension, and blood loss. If they're still pale, consult your veterinarian. So if they have a prolonged CRT, so your refill is getting to be greater than 2 seconds, that suggests poor perfusion and potentially hypotension. This could be pre-existing already in patients that have been through some kind of traumatic experience, blood loss, and then also certain drugs such as ACE or inhalants. Again, check their pulse and their blood pressure, see what their MAP is. If the pulse is reduced, check them for signs of shock, such as hypothermia and tachycardia. So pulse pressure, even though they may have a high heart rate. Dyspnea and cyanosis. So dyspneic, those difficult breaths, the animal is not getting sufficient oxygen and is not able to properly remove CO2 with its normal breathing. And cyanosis means they're not getting enough oxygen and the tissues are becoming deprived. And if not managed, this will lead to respiratory arrest. This could be caused by a lack of oxygen, so make sure your oxygen tank is working, make sure your flow meter is on and at a proper level, and that their ET tube is properly placed and not blocked. And then also, again, too deeply anesthetized. If they're unable to breathe normally, make sure there's no ET tube blockage or kink tube. Laryngospasm, so is their larynx spasming and not allowing them to take breaths. Have they aspirated stomach contents and then inhaled them, which is causing breathing issues? A brachycephalic patient, just that alone can be dyspneic and cyanotic. And then if they have any issues such as pulmonary edema, so fluid in the lungs, diaphragmatic hernia, pleural effusion, and also you could be dealing with even things like pneumothorax, things like that. Any of those can cause breathing difficulties. So what to do? Make sure that they are getting oxygen. Flow meter is working, oxygen's working, ET tube is placed properly. If all of that is good and they're still dyspneic and cyanosis, you most likely want to turn off the vaporizer and get them oxygen. Bag the patient with 100% oxygen and make sure the chest is moving when you give them breaths. You may, if there is some kind of blockage, if some kind of laryngospasm that's even blocking the tube, you may need to perform a tracheostomy to get oxygen directly into the lungs. IV fluids and rescue drugs, you have to be careful with those. Or with IV fluids, you don't want to cause pulmonary edema, anything like that. That can be helpful with blood pressure, maybe not with breathing difficulties. Drugs may help. They may help open up the lungs a little bit. You want to monitor heart rate for cardiac arrest and continue oxygen during recovery. So tachypnea, this is different from dyspnea. Dyspnea is difficulty breathing. Tachypnea is fast breathing, so panting. It could be caused by opioids. It could be caused by they're not deep enough, especially if there's pain. And if they are deep, response to low oxygen and too much CO2, so they're not being able to breathe out properly. Also hyperthermia, they're hot, and obese patients tend to get tachypnic very easily. So check their anesthetic depth. Again, make sure they're deep enough. Also make sure that the CO2 absorber is working. A capnograph will let you know if they're getting out the proper amount of CO2. Check their body temperature. If they are too hot and you adjust things, it should resolve. If surgical stimulation is the cause, so this has happened after the surgeon has started cutting or is manipulating, you may need to give pain meds. You may need to give some kind of CRI of pain meds. And if they're obese, you may have to help with ventilation, either by hand ventilation or turning on a ventilator if you have one. So remember abnormalities in heart rate and rhythm, tachycardia, under anesthesia, large dog over 140, small dog 160, cat 200. It's going to be caused by drugs, diseases, surgical stimulation. May or may not require treatment. Make sure you check your vaporizer and check your anesthetic depth. Also the low range, so dogs below 60, cats below 100. Remember to keep in mind the size of your animals, so small dogs and big dogs may have different ranges. Could be caused by drugs, increased vagal tone, endotracheal intubation, ocular surgery, handling of viscera, deep anesthesia, hypertension, hyperkalemia, hypothermia, and hypoxia.